Thanks, Chuck. I appreciate that. And thank you for inviting me. I know there are a lot of NTM bronchiectasis conferences that go on across the country and across the world. And this is the only one I've been to. And I don't think there probably are a lot of gastroenterologists at those conferences, my guess. And I think hopefully we can touch today on why this really is important. And hopefully we do end up seeing a lot more GI doctors at these bronchiectasis conferences. And a lot of what I'll present today maybe or is very similar and if not the same to a lot of what I've presented in previous years. I did add a couple of new things on today. So sorry if this is review for some of you. I will talk about two medications later on in the talk, and I'll discuss their off-label use. I'll discuss how they're used to treat reflux. So just wanted to make that disclosure. And so we're going to walk through a few things here. We're going to talk about how GERD affects NTM pulmonary disease. We will talk about different ways to test for reflux and the pros and cons of testing, as well as how to interpret those tests. And then we'll also talk about how to treat reflux. And this, what I will really try to hone in on is how this may be very different when we're thinking about treating reflux from a lung standpoint to how we often classically treat reflux from an esophagus or a GI standpoint. And so we'll talk about the relationship between the GI tract and the lungs. As I said, we'll go through testing and treatment. So why is a GI doctor here talking at a pulmonary NTM conference? Well, the reason is that the airway and the GI tract are very closely related. In the back of your mouth, your throat is one tube, and when it gets down here to your neck area, it breaks off into two branches. My world, it starts right here at the top of the esophagus and goes down into the stomach. But there's another tube that breaks off, goes through your vocal cords and down into your trachea, into your airway. So the airway and the GI tract are right next to each other. And as you heard Dr. Lomash discuss, one of the things that we worry about in bronchiectasis and NTM infection is aspiration. It's stuff getting down into the airway that shouldn't. And there's really only two ways that that can happen. Either coming from the top and going down the wrong way when you swallow, or it goes down the right way and then it comes back up from below. And if it's coming up high enough to get above the esophagus back into your throat area, it may be sneaking over into your lung from that direction. So there's a few terms here that I kind of alluded to that I just wanted to make sure that we define, that we're all on the same page when we talk about them. So the title of the talk is GERD. That stands for gastroesophageal reflux disease. So gastro refers to the stomach, esophageal refers to the esophagus, and reflux is contents from the stomach coming up into the esophagus. The D part of it, disease, is when that flow of contents causes a problem. And that can be standard heartburn and digestion type issues, or it can be actually aspiration. There's another term that you may hear tossed around called LPR, or laryngopharyngeal reflux. The larynx and the pharynx are in the sort of throat area. And so this means reflux that's coming up above the esophagus and getting into the throat and upper airway area. And then aspiration, we just talked about that. That's where stuff can get over into the lungs. That's not air, and that can either be coming from the top or from the bottom up. And then there's a fourth term. This is a term I put for the first time on my talk last year. This is a new term that there are probably 20 people in the world who have ever heard this term, besides all of you who may have listened to this last year. I do a lot of work with the cystic fibrosis group. We have the largest adult cystic fibrosis clinic here in the country. And as part of the Cystic Fibrosis Foundation's initiatives to try to learn more about why CF patients were having more lung issues and people who have had lung transplant were not doing well after transplant, they wanted to look into the context or the contribution of reflux to this. And so I was part of a group through the Cystic Fibrosis Foundation that we basically presented on what is known about the overlap of reflux and lung disease. And what we learned at the end of 4 months of conferences is that we really don't know very much about this. But the one thing that did come out of this is this term called that we called GRASP, or GI related aspiration. So you'll hear a lot about we're going to evaluate you for aspiration. We think you may be aspirating and that's contributing to your lungs. But the question is that coming from above and going down into the lungs? Is it coming up from the bottom? And so this GI related aspiration is really to refer to stuff that's coming up from below. And a lot of the other reason why we developed this term is because a lot of people use reflux and aspiration synonymously. It's the same, like it's the same thing. Well, there's a lot of things that can lead to stuff coming up and getting over into your lungs. There can be problems with how food and liquids are moving through the esophagus. There can be issues with problems with your stomach not emptying out properly. So there are a lot of this term sort of encompasses a lot of different GI contributions to lung disease. So we're in the process of putting together a paper right now that will hopefully be published within the next few months to get this term out into the literature. And my hope is that people start using this term or hearing this term more. So how common is reflux in the general population? So about 2/3 of patients will experience reflux symptoms. Again, most typical reflux symptoms being heartburn, indigestion, and regurgitation, that feeling or tasting stuff come back up. So that's over a year, about 60%. About half of those patients actually have symptoms on a monthly basis. About half of those patients have symptoms on a weekly basis. And about half of those patients have symptoms more than twice a week. So this is a very common issue. Now, again, this is reflux. This isn't necessarily getting into the lungs, but this is reflux. So what are the manifestations of reflux? Well, these are the ones that everybody kind of has heard of, right? That's reflux, heartburn, irritation and damage to the esophagus, Barrett's esophagus, which is a potentially precancerous change in the lining of the esophagus caused by reflux, and then cancer. Well, what we really are going to be focusing on here is what happens when that reflux gets above the esophagus, and that can cause sinus issues, it can cause cavities, and it can, if it's getting down into the lungs themselves, there are other issues that can pop up. And so here's sort of looking at a number of pulmonary issues that have been associated or thought to be associated with reflux. And so, what's very important to understand is some of these are directly a result of reflux, such as aspiration pneumonia, ground glass opacity. These are kind of abnormalities seen on a CAT scan. A lot of the other things on this are underlying conditions that may be made worse, exacerbated, changed, or altered by reflux. And again, bronchiectasis is on there, asthma, we have cystic fibrosis, COPD. So there's a lot of very common lung conditions on there that can be exacerbated by reflux, not necessarily caused by reflux. So what do we know about reflux and NTM? Well, as Dr. Daly alluded to earlier, that NTM are in our environment, in the soil, in the water, so we're always coming in contact with these things. So one of the theories about how does it make it into your lungs is that you ingest it through eating and drinking. It refluxes back up from your stomach. It sneaks over into the lungs. And this is important, in the proper host setting, this can cause chronic infection. And so whether that's an immune-related issue, whether that's an underlying structural problem with the lungs that already exists, the NTM gets over there, it sets up shop, and it becomes a chronic infection, sometimes leading to symptoms and requiring treatment. I'm going to get into a couple of papers. I'm not going to get deep into the weeds on this, but this is just this is a study that looked at people with MAC and then they used controls, people without MAC, and they looked at the prevalence of reflux in these patients. And what they saw was that the folks with MAC, about 40% of them had reflux, and only about 25% of the folks without MAC had it. So this there's thought to be an increased amount of GERD that we see in our NTM or MAC patients. This is another study. This is looking actually kind of the opposite way of looking at people who have reflux versus people who don't have reflux. And in those that had bronchiectasis, the folks that had reflux had more parts of their lung. So this is the number of lobes of the lung involved with bronchiectasis. The people who had reflux had twice as many parts of their lungs involved by bronchiectasis. So this is kind of suggesting that there is some sort of correlation that people with reflux tend to have MAC or NTM, and people with NTM and bronchiectasis seem to have more significant or potentially more severe disease when there is reflux around. This is a study that looked at over 1,800 patients in the United States with bronchiectasis, and 2/3 of those patients were NTM patients. There was a smattering of CF and other causes of bronchiectasis in that group. And they saw that the NTM patients, 51% had GERD. And again, if you didn't have NTM, you had less chance of having reflux. So there is this theory of NTM making it into the lungs from reflux and aspiration. There are studies out there that are highly suggestive. This is a new study that came out last year, I believe, from the Korean National Health Service. And what they looked at is they took reflux patients and they matched them with non-reflux patients over the course of 10 years. And they diagnosed, or they defined reflux in this study based on billing codes and based on patients who had been on PPIs, which are strong acid reducers, for over 3 months. As an aside, what you will maybe start to learn as I talk through this is the definition of reflux is variable. How we define reflux, who has it, who doesn't, what studies use to say this is a reflux patient and this isn't, is variable. And this is one of the things that came as part of this workshop series we did with the CF group, is when you look at the studies that are out there that are looking at reflux and lung disease, every study seems to define reflux differently. So it's hard to have a homogeneous group to really learn anything from. So here, they actually didn't do any formal testing. They just said who's on reflux medicine, or who's in their chart, it shows up that they have reflux, and that's how they defined reflux. And then what they did is they followed these patients, reflux versus no reflux, and they tried to see who developed NTM. And what they saw was that so this is the incidence of NTM over the course of the study, 0 to 12 years. And what they saw was that the folks with reflux actually had a higher incidence of NTM than the folks who didn't have reflux. And when you look over here, this is healthcare use, respiratory disease related reasons to seeking out healthcare, that the patients with GERD and NTM pulmonary disease, they saw the doctor a lot. They had issues. And the folks that had reflux without NTM pulmonary disease, that was usually a little bit easier to manage and didn't run into as many problems. So again, another suggestion that there should be this, we should think about this correlation of reflux and NTM. So that gets to the magic question of how do we actually detect, or if grasp, this GI related aspiration is at the root of all of this? Well, how can we detect that? How can we treat that? The answer is we can't. And this is what we came up with after the end of this lecture series that we put together, workshop series, is that nobody has any idea or any test to definitively say that you are having reflux that is getting into your lungs and causing problems. That test does not exist. And this probably explains why there are no GI doctors at the NTM conferences, because nobody really has the right answer. A lot of this is kind of anecdotal and it's based on reflux studies. So what can we measure? Well, we can measure reflux. We have testing. We'll get into that, how we measure how much stuff is coming back up. We can measure how things are moving through the esophagus. We can measure how things are moving through the stomach. And we can also measure pulmonary things like cultures. We can do CT scans looking for inflammation and damage and pulmonary function testing. But there is no agreed upon criteria for diagnosing GRASP. And the reason why I want to highlight this is the importance of finding a facility that approaches NTM from a multidisciplinary perspective. I tell all my patients, some of whom are in the room, this is a puzzle. And each test that we do here is a piece of that puzzle that when you put it all together at the end, says it's likely that you have reflux getting into your lungs or it's unlikely. And there's not one of these tests by itself that can definitively tell us that. They're all increasing your risk or decreasing your risk of having this as an issue. But this is really, really, really important to understand. As I said, the current testing really defines the risk of having GRASP. So what testing do we have? This is where we get into the not so fun part of the talk. So the main test that I typically order when this question comes up in my clinic is called a pH impedance study. This is a torture device where we put this thin, flexible tube. Those of you who have had it understand what I'm talking about. I've been here for 10 years. I used to say I was going to get this done so I knew like what the patients were going through. And then after being here for like 5 or 6 years, I'm like, nah, I'll take your word for it. Yeah. So this is where we stick this little thin flexible tube in your nose. It goes down your throat, dangling in your esophagus. It hangs out of your nose, taped onto your face, hooked up to a recording box. And that's not even the fun part. The fun part is then we send you home for 22 hours. Or 24 hours, some places will do it. And while it's in there, you eat, you drink, you sleep, you go on a walk, you live your normal life, and you come back the next day and we take this tube out. And that tube has sensors all along it, these little beads, that are constantly able to measure whether or not there is liquid basically coming up into your esophagus from your stomach. So even if you don't feel your reflux, if you don't have heartburn, even if it happens at night while you're sleeping and you're unaware, this test is going to tell us how often are you having reflux. Because there are sensors along the whole tube, it will tell us how high does that reflux go. Not, with lung issues, we're worried about it coming all the way up here where it's getting into your lungs. We don't really care how much gets up into the end of your esophagus from a lung perspective. We care what's going on up here. And the sensors are also able to tell us if you are having reflux, what type of reflux is it? There are two types. There's acid reflux. That's the one everybody has heard of. And all the medicines out there are used to treat acid, Nexium, Prilosec, Pepcid, all that. There's a second type of reflux that most people have never heard of, which is called non-acid reflux. And what I mean by that is we have other stuff in our stomach besides acid, like food and drink, bile, other digestive juices that are not acidic, that can also be coming back up. And if that's getting over into your lungs, that's just as much of a problem as acid is. And in a second, we'll get into why that may even be more of a problem than acid reflux. But this test is able to measure both types of reflux. So it's a pain in the butt, pain in the neck test, pain in the nose test, but it really helps us answer this question. There's a second type of reflux testing that I think is more sort of GI related, but a lot of patients will come in having had it done elsewhere. And we do it here quite a bit as well. It's called the Bravo pH study. This one is done while you're asleep. We do an endoscopy, put a camera down into your esophagus. And while we're down there, we can clip this little plastic sensor on to the inside of your esophagus. It's held in with a little stainless steel pin. It kind of gets stapled to the lining of your esophagus. And so when you wake up, there are no tubes hanging out of your nose at all. You have this little recording box that you carry around with yourself, usually for 4 days. This recording box comes back to us after 4 days. The clip eventually falls off on its own and you pass it, it's disposable. We'll get in on the next slide what the difference really is between these two tests. So as I discussed, the impedance study is usually 22 to 24 hours, whereas the Bravo is usually 4 days. So this is kind of a better reflux test because it measures for a longer period of time from that standpoint. However, the impedance, because it's a tube all along the esophagus, we can measure how high that reflux is going, whereas the Bravo only measures how much reflux is coming up into the very end of your esophagus. Discomfort, clearly the Bravo is, patients like that one more. They like not having the tube hanging out of their nose. Both of them detect acid reflux, but only the pH impedance study detects non-acid reflux. So a lot of the times people will come into my clinic and say, my local GI doctor, yeah, they thought about this back home and my GI guy did a Bravo test and I don't have a reflux problem, right? And then we sort of have this conversation and I say, well, let's back up. It's like, you may not have an acid reflux problem, but it doesn't mean you don't have a reflux problem. And that's why understanding the types of reflux tests is important. So how do we treat reflux once we think that it's contributing to your lung issues? There are 3 mainstays of reflux treatment: lifestyle modifications, and I'll include diet in there, medications, and anti-reflux procedures or surgery. So this is a guideline put out over 10 years ago by the American College of Gastroenterology. This is a National GI Society that puts out recommendations about how to treat reflux. And so this is looking at efficacy of lifestyle interventions on reflux. I highlight the top 3 things, which are weight loss, elevating the head of your bed, and avoiding late night meals. The reason why I highlight these are the ones where there actually is some sort of recommendation by a national GI society that this may help reflux. Now, what do I mean by that? So weight loss improved GERD symptoms and it improved pH. So it improved acid levels in the esophagus, right? Whether or not that's relevant to lung issues, I have no idea. Head of the bed elevation, usually that means elevating the head of the bed 4 to 6 inches or 30 to 45 degrees. That improved, again, pH and symptoms. And then avoiding late night meals improved acidity, basically in the GI tract, but didn't have any effect on symptoms. So these are studies that are, again, they're not random. Only one is a randomized study. These are kind of poor. We don't have a lot of studies to really answer these questions. But on the other hand, these are a lot of things that you've all been told, that these are important things to do to try to limit the risk. Whether or not that's terribly helpful, again, unclear. The other things down here, avoiding chocolate, caffeine, spicy foods, citrus, carbonated beverages. No studies performed, no evidence that. Now, that doesn't mean don't do it. I thought I just saw lightning outside from Dr. Hewitt, like trying to strike me down when they said that. It doesn't mean don't do it. Just because we don't have studies, it doesn't mean don't do it. But what I do tell people is that we do have these ways to study reflux, to way to look at your particular reflux characteristics. And that not only tells us, do I have abnormal or normal amounts of reflux, but it can also tell us what time of day am I having my issues, right? And if all of your reflux is happening at 3 a.m., your 2 cups of coffee that you have at 8 a.m. probably aren't a big deal, right? And maybe that's not where we have to focus our attention. On the other hand, if all of it is at 9 a.m. and you have nothing going on overnight, well, you probably don't need to sleep like an astronaut standing up Velcroed to the wall. You can probably lay down, right? So this is further recommendations about what are the recommendations regarding controlling or managing reflux that's getting above the or outside of the esophagus into your lungs. So what this says is use of once or twice daily PPI. So that's strong acid reducer. Do you need to be on an acid reducer? If you're having cough, NTM, if we think that reflux is contributing to your lung disease. This says that they recommend using one if you also are having standard reflux symptoms. If you have heartburn and indigestion, then sure, be on an acid reducer. If you don't, in the absence of GERD syndrome, reflux indigestion, they recommend against the use of acid reducers in these patients. So just because we think reflux may be contributing to NTM, that doesn't mean you should reflexively be put on an acid reducer. And why is that? Well, here's a study from 2008. This is looking at the upper esophagus, the middle of the esophagus, the end of the esophagus, number of reflux episodes on PPI and off of PPI. You have the same number of reflux episodes, whether or not you are on an acid reducer. Here's another study. Total number of reflux events. This is before patients are put on treatment. They broke them down into the two different types of reflux. Here is acid reflux. This is non-acid reflux. Then they put people on omeprazole twice a day, Prilosec, twice a day for a week. And they stuck the tube back down their nose overnight and they saw how much reflux they had. You can see that the total number of reflux events is similar. But what happens is the acid number basically goes close to zero, right? The acid reducer controls acid reflux, but it doesn't stop the stuff from coming back up. It just changes those reflux events over into non-acid reflux events. So everything shifts from this column into this column. So PPIs, what they do is they reduce acid. They do not reduce reflux. They don't keep stuff from coming back up. Dr. Honda, who's going to be speaking later, when she was here several years ago, did a study where she actually grew Mycobacterium abscessus in different pHs and in different conditions. And this, I'll sort of point you, and Dr. Honda, correct me if I say something incorrect here, but this slide, part of the slide down here is looking at the air-lung interface. So this is sort of mimicking the sort of lung environment. And what you see here is in the white columns, these are mycobacteria levels at a pH of 7.5. So that's when mimicking the stomach environment in someone who is on a PPI. So this is a basic environment. And you can see that over time, the M. abscessus levels actually increase. Whereas if we mimic the stomach, a pH of 2, yes, initially you have mycobacteria in there, but very quickly, the acidic environment kills the mycobacteria and they go away. So this sort of raises this question of not only by putting people on PPIs, are we not changing how much reflux we have, but are we also creating an environment that if you are ingesting mycobacteria from your water source or whatever, now it's hanging out in your stomach longer. And if you are refluxing, now it may be bringing with it more mycobacteria. So are there medications that actually reduce reflux? There are two that I will talk about, and these are the ones that I alluded to that I'll talk about off-label uses. So neither of these is a reflux medicine. Baclofen is actually a muscle relaxer used by neurologists for people who have spastic muscles in their back, their neck, their arms. Interestingly, the sphincter muscle, which is a muscle that you have right where your esophagus attaches to your stomach, that muscle is supposed to be nice and tight to keep stuff from coming back up. Baclofen actually works differently on the sphincter muscle. So instead of being a relaxer of that muscle, it prevents relaxations of that muscle, works the opposite. And the longer you can keep that muscle tighter, the less chance you have of anything coming back up, acid or non-acid. So this looked at healthy volunteers and reflux patients. Let's focus on the reflux patients here. And they looked at total number of reflux events on placebo and then patients who are on baclofen. You can see a drastic decrease. And if you look, it decreases acid reflux events. It also significantly decreases non-acid reflux events. So this is a very different slide than what you saw in my previous slides where we were treating reflux with acid reducers alone. Now, the other thing I will point out here is that it never goes to zero. So any of the things we do, whether it's diet, lifestyle, medications, is never going to take reflux out of the equation. It's never going to get it to zero, but it's significantly mitigating the risk of reflux potentially getting over into the lungs. There's another medicine called bethanechol. This is actually a urology medicine to help the bladder empty out better. In addition to making the bladder squeeze and empty out more fully, it also makes that sphincter muscle squeeze. There are some basic science laboratory data to show it can improve the clearance of things through the esophagus, getting them away from the lungs. It can increase pressure of that lower esophageal sphincter. And there's anecdotal evidence, at least in my practice, that when we do studies of people on bethanechol, we see far reduced number of reflux events. So these are two medications that we use here very, very frequently to treat reflux that are a much different approach to medical management of reflux than standard acid reducers. As I said, there are no reflux studies on bethanechol. So what surgeries do we have? As I said, that sphincter muscle is really the important area here. The tighter that muscle is, the less stuff comes back up. The looser it is, the more stuff comes back up. The tighter it is, the less stuff comes back up. So if we've done all the lifestyle things, if we've done all the medications, and you're still having reflux that we think is getting over into your lungs, the next step is to tighten that area up physically. Well, how do we do that? There's the standard anti-reflux surgery is called the Nissen fundoplication. It's been around for decades and decades. And basically laparoscopically through a few small slits in your abdomen, they take the top part of the stomach and they wrap it around the end of the esophagus and suture it in place, and basically making a belt around the end of your esophagus to hopefully keep things from coming back up. Now, the downside to that is, well, the upside is now that area is tight and reflux doesn't happen as much. That's great. But other stuff you want to come back up also doesn't come back up very easily. So if you want to burp, if you have to throw up, can't do that, or usually cannot do that after a fundoplication. Also, now you're swallowing, maybe you don't chew things quite as well. Now it might have a harder time getting through that area. So people can develop swallowing issues after the surgery. So there are downsides to it. Sometimes for that reason, they'll do what's called a partial fundoplication, when instead of wrapping and really tightly wrapping the thing all the way around, they just kind of do a half or a 3/4 wrap of that. And then there's a newer device called the Lynx procedure. This has been out for probably 15 plus or minus years at this point. It's a magnetic beaded bracelet, basically, that they surgically implant around the end of the esophagus. And this kind of mimics the normal sphincter muscle. These beads are magnetic so that if you need to throw up or swallow, enough pressure can be generated to actually pull the beads apart. So it can open as food is going through, and then it closes back up again. So this is kind of more mimicking physiology. So the take-home points from this is that the GI tract and the airway are very close together. The GI doctors should be at the NTM conferences and the bronchiectasis conferences. GRASP likely plays a role in NTM infection, but we're still not there as far as being able to definitively say. All the reflux testing, I told you, the best reflux test we have is this tube. We're not measuring reflux getting into your lungs. We're measuring reflux coming up to your throat, where it's right next to the lungs, where if it's coming up there and everything else looks like it's getting down to the lungs, probably is, but we don't have a way to actually measure that it's getting down into the lungs yet. If we're thinking about grasp, choose the proper reflux test and interpret it properly, right? Look for acid reflux and non-acid reflux. And what we didn't get into is really interpreting the test results from a lung perspective may be different than interpreting them from a GI perspective. So seeing a GI doctor who understands this overlap is important, but hard to find. That's probably even putting it lightly. Hard to, barely exists in the world. Not all reflux is acid, and acid reducers don't reduce reflux. So treat reflux in a way that reduces your risk of aspiration. And that includes things like lifestyle modifications, medications, and potentially surgery. That's it for my talk. I'll take any questions. Now, I'm not as smart as Dr. Lomach, so don't ask me. You asked him GI issues like celiac disease. Don't ask me about asthma or COPD.
Thank you, Jeff. Question?
About 12 years ago, I did come out and get the complete workup, and Dr. Hewitt said, I have silent reflux. I have no symptoms, a small hiatal hernia. Can you explain a little bit more what she meant by that?
Sure.
Perhaps.
Sure, that's a great question. So as I mentioned before, there are classic symptoms that we think of as being due to reflux. Heartburn / indigestion, that burning sensation behind the sternum that kind of comes up from below, and regurgitation, that tasting or feeling stuff coming back up. If we do a test on you, whether that's a barium test, whether that's a CAT scan, whether that is one of those fancy reflux tests, and we find that stuff is coming up from your stomach, but when we see you in clinic, you tell me, I don't have reflux, like I don't have heartburn, I don't have regurgitation. That's what we call silent reflux. So it's stuff that's coming back up that you don't know about and you're not aware of. And I've had people sit in my office and swear up and down they don't have reflux. I just cough. I don't have reflux. Why are we talking? I traveled here from Texas. I spent all this money, a week of my time. You're trying to stick this tube down my nose for 24 hours and make me miserable. I don't have reflux. There's one person I'm thinking of. She was coughing for 8 years. She came back later the week. We went over, I talked her into doing the test. She had 120 episodes of non-acid reflux in 22 hours. Now she's at one end of the spectrum. But the point is, until you do this testing, we have no idea how much reflux you have or don't have. It may correlate with your symptoms and it may not. So that's what we mean by silent reflux.
The opposite would be noisy reflux.
Noisy reflux is the opposite of silent reflux. That's right. That's what pays my bills, noisy reflux.
Hi, I've had all these tests and I've been told that I aspirate from my stomach into my lungs. And I have a hiatal hernia and I'm trying to decide whether to have this very good doctor in the area do hiatal surgery. What do you recommend? What do you recommend? The links.
So,
she wants to do the links, I believe.
So this little muscle right here is the diaphragm. That's a breathing muscle. It sits under your lungs and it moves up and down. That's why you breathe. And everything above the diaphragm is the chest cavity, and everything below the diaphragm is the abdominal cavity. And the esophagus, where it attaches to the stomach, has to pass through this little opening in the diaphragm. That's called the hiatus of the diaphragm. So when some of the stomach slides up through that hole in the diaphragm and you wind up with a little bit of your stomach up in your chest where it doesn't belong, that's what a hiatal hernia is. And when that happens, it tends to loosen up this area a little bit and it makes you more prone to having reflux. Doesn't mean you're gonna have a reflux problem, but it means you're more likely. It also means if you do have reflux, you may be less likely to respond to traditional treatments. I can give you medicines and tell you not to drink coffee and all that stuff to try to keep that sphincter muscle tighter. But if that area is so loose from the hiatal hernia, baclofen, bothanicol, those medicines may not help. And eventually, if we can see evidence on formal objective testing that there's significant ongoing reflux despite doing all those other things, then usually we will recommend going in and physically getting the stomach back down where it belongs and tightening that area up. And so what I would say is, I think it sounds like it's a reasonable thing to consider, but I would say that doing objective testing to verify that there is significant ongoing reflux is very important, and to make sure your esophagus is moving and working properly. Because if things are not moving well through the esophagus, the last thing you are going to want to do is put your stomach back down where it belongs and tighten that area up. Because now you fixed one problem, you stopped the reflux from happening, but now nothing's going to be getting through your esophagus into your stomach, and it's going to be backing up in your esophagus and getting over into your lungs still. So you're trading one issue for another. So that's where I think it is important to make sure that there's a lot of testing to verify normal esophagus movement, verify that you have significant ongoing reflux. And if you've met those criteria, then yes, I think it's a reasonable thing to consider.
Okay, thank you.
Two questions, if I may. Fund duplication, if you had a fund duplication earlier, is that ever going to be reversed, or will it reoccur again over time?
So the data on fundoplication says about 25 to 30% of the time that wrap that they do will loosen up over time. Your hiatal hernia may come back. You may need to have a repeat fundoplication performed. There's also data showing about 25% of people after a fundoplication still need to be on reflux medication. So I have a lot of people coming in saying, I just want the surgery. I don't want to take all these reflux medicine anymore. Well, it's not an either or. It's not that easy. There are people who have complications of the fundoplication where it is too tight and they're developing all these swelling issues. And sometimes those patients, the surgeon will have to go in and basically remove take it down. So there are a lot of issues that can come up, and that's where it's important to make sure that it's the right option for you at that time, and that you understand that it's not, you just get it done and never have to think about it again.
So the other question relates to when you're doing postural drainage, airway clearance, as Dr. Lomax says, one of the most effective ways is the downward facing dog is your last step of that. Let gravity do its work. How is that affecting somebody who's had this procedure before?
Yeah, well, in general, certainly gravity plays a role in, there are a number of things that play a role in reflux and how much stuff is coming back up. Gravity is one of those things. When you last ate, what the pressures are in that sphincter muscle in your stomach, what the pressures are in your chest versus your abdomen. There's a lot that goes into that. That is one component of that. Now, I've never seen a study that looked at, I don't know, patients getting pH impedance study in yoga class to see what different positions and how that affects. It's just kind of, you assume that being upside down and not having gravity on your side, you're going to increase your risk of stuff coming back up and getting into your lungs. But there's no studies on that.
We're going to need to take a break, but could you stay around for 10 minutes or so?
Yeah.
So if you have questions, please come up and talk to Dr. King. Let's reconvene in about 15 minutes at 11:35. We'll give you a call when it's time to come back in. Thank you very much, Jeff. That was great.